Welcome. It's been an exciting day for Global Health Day with a series of, with a couple of talks from eminent personalities and, a really impressive set of posters in the hallway as well, showing really the depth and breadth of the work that we're doing in global health. I am just delighted to introduce Dr. Olusoji Adeyi to you today for a number of reasons. This is a long overdue presentation from somebody who is supposed to be one of our centennial speakers during our Bloomberg centennial, but he got some snowstorms got in the way of our great plans, and so although he's come back to work with us and share his work with us since then, we've taken the opportunity today to have him talk with us. So Soji Adeyi is the director of the Health, Nutrition, and Population Global Practice at the World Bank. This means that he is the chief operating officer for about a $12 billion portfolio in health, nutrition, and population at the World Bank. That involves credits, loans, and analytic services, focusing in low-income countries and low and middle-income countries around the world. He's got I'm not going to read you his whole history, where he has come from, but he's worked in a whole number of agencies, from the Ministry of Health in Nigeria to the World Health Organization. You were at UNAIDS and the Global Fund for AIDS, TB, and malaria, as well as working at some other school of public health a few miles up the road, where I think somewhere in Boston, I'm told. No, he worked at the Harvard School of Public Health as well. He has come from, he sits on many advisory boards, both for policy programs as well as for academic purposes, and he has a good pedigree. He is a graduate of the University of Ife Medical College in Nigeria. He did his, I don't think this is chronological order, but it has an MBA from Imperial College and an MPH from the Liverpool School of Tropical Medicine, and most importantly, he did his Doctor of Public Health here at the School of Public Health in the Department of International Health. So I am very happy to turn over the podium to Soji Adeyi to talk about the future of global health systems. So welcome here.
Thank you, David.
Thank you.
Thank you very much, David. Good afternoon, colleagues. It's always nice to come back to Baltimore, and it's always especially nice to come back to the Johns Hopkins Bloomberg School of Public Health. Thank you for having me back. And hello to colleagues who are online. I'm very delighted to be here and for this opportunity to engage with you in a 1-hour exploration of global health systems. Where are we? What is coming down the road? And in that context, what challenges do we face together? And I want to urge in particular that you look at what we discuss in the next hour or so through the lens of this great school, which has that very interesting catchphrase of saving lives, millions at a time. So I think it's fair to say that over the last 50 years in particular, and in an accelerated fashion, we've seen great progress in global health, especially health outcomes, particularly child health and maternal health in many parts of the world. Progress has been uneven, as you know. But that is not the sole focus of our discussion this afternoon. This afternoon, I would like to encourage us to think along 5 main themes and the intersections among them. The systems for health, but more importantly, those cross-sectoral factors that influence health. To think about the macro trends and the macro factors affecting both the demand side and the supply side of health, the challenges that are persistent and the new ones, and what I will call, for want of a better expression, that vexing quest for a balance between the roles of the state and the market. Finally, in this era when somebody has colorfully used the phrase alternative facts, I would like us to take a very close look at evidence in health and also to think about the extent to which evidence drives policy or the extent to which politics drives evidence in global health. And since we're in the Holy of Holies at Johns Hopkins, spoiler alert, if you listen very carefully to those who are graduate students, there are quite a few doctoral thesis questions waiting to be answered. So please pay attention. Now, the determinants and producers of health extend well beyond health systems. We all know that. But let's focus intently on what I would call the factors, the actors, and the relationships, as well as the influence makers and influence receivers there. And in the era of the SDGs, this is a completely unbiased slide, you know. It's utter coincidence that box number 3 there on good health and well-being is the biggest one. However, let's pay attention to those other boxes because they're crucial. I'm talking about things like climate action. Yes, climate change indeed is real. About hunger, clean water and sanitation, the persistent effects and relevance of quality education, the empowerment of women, and the transgender, the cross-gender factors that play out every day in towns and villages all over the world, and all of which affect health. Now, demography may not be destiny, but demography is very important. In some countries that are still pre-transition and pre-demographic dividend countries, you still have very high total fertility rates. I'm thinking, for example, of Niger Republic. Whereas in some other countries, they're aged or rapidly aging societies, and each of those presents its own set of challenges to the policymaker in terms of the demand for services, the struggle among different segments of the population for those services, and an unending battle, if you might use that phrase, among different interest groups that engage in daily transactions and bargaining over what is really important. Who is going to pay for it? How are the benefits going to be distributed within the same generation, and I dare say across generations? Globalization has its own impact on what we do, what we experience, in terms of the movement of people, the movement of ideas, the connectivity of ideas, and the effect on, 1, disease transmission, and 2, opportunities to harness some of those new technologies and openness in service delivery. All of those affect what we do. Rapid urbanization in many places, and therefore, whereas a generation ago, we probably obsessed, rightfully, principally over underserved rural populations. These days, we worry not only about underserved rural populations, we do worry, rightly I might say, about underserved populations in urban slums. So where does this leave us regarding urban health? Mega cities, the demand for food, food yield, crop yield, and the changes and relationship between this and climate change. All of these have a bearing on health. Now, in practical terms, for our colleagues who are policymakers in health, sitting in the Ministry of Health, or those who are sitting in the offices of the social sectors, as they are called, the ministries of finance, the reality is they now have to figure out how to cope with the combined burden of what you might call the traditional maternal and child health challenges and infectious diseases, as well as the chronic non-communicable diseases. So it's no longer a choice, it's a combination. So we're looking at integrated models of care. Our credit goes to the World Health Organization for this framework that is illustrated here. And crucially, we're looking at cost trajectories, because the choices that countries make, whether those choices are choices of omission or choices of commission, will have an effect on whether or not the cost trajectories of their services are high cost trajectories or low cost trajectories, and there are trade-offs there. Was in Ghana last week, and this was one of the discussions we were having with our government counterparts. What do you do to really place emphasis on primary prevention and secondary prevention so that you do not end up treating the tertiary, more expensive levels of care, things that could be managed at much lower levels of the service delivery chain? In my institution, we are working with countries in the Baltic region on related questions. And I know that these are pressing issues in Latin America, there are pressing issues in South Asia, and there are pressing issues in East Asia. So these are global concerns, and they express themselves differently. So for those of you who remember your literature, I think Anna Karenina, I believe, said, every unhappy family is unhappy in its own way. I dare say every unhappy health system is unhappy in its own way. And of course, financing and equity come in. We'll talk a lot more about equity as we go on. Well, we got quite a scare a couple of years ago from the outbreak of Ebola in West Africa, and I think that helped to concentrate minds. It's fair to say that there will be outbreaks. We don't know where they will originate from, and we don't know what the pace of spread will be. And so the two questions are, how do you avert massive, disastrous scale of outbreaks, and how prepared are we to respond? How prepared are the countries to respond? The Ebola outbreak was especially damaging in the West Africa sub-region where it raged. But of course, the economic impact was felt far beyond. And I think institutions are now waking up to the importance of investing in these areas. Countries are waking up to the importance of investing a lot more in these areas. And among all of this, one of the gems that is emerging, is still very early days, I think is the decided effort of the African Union to actually put in place an African Centers for Disease Control and Prevention. I had the honor of being present last week in Addis Ababa at the first scientific conference of the Africa CDC, looking at its first 5-year strategic plan. Antimicrobial resistance. Are we going back to the days when antimicrobials did not exist, quote unquote, because in this context they might be ineffective? And what are the tremendous implications of that? These are real, this is not science fiction. So understanding the phenomenon, which is essential for ensuring effectiveness to life-saving antibiotics, and realizing that this goes beyond a medical matter. It actually cuts across humans, animals, and the environment in what is labeled as the One Health approach. And again, the interconnectedness of all of this. Pollution, indoor air pollution, ambient air pollution, accounting for a significant and growing proportion of the total burden of avoidable morbidity and premature mortality is something we have to deal with. And of course, we know there is disproportionate effect of this in low-income countries, and even within high-income countries, it is disproportionately concentrated among the poor, and that is true of the country in which I stand right now. So this is one of the major factors that we confront in global health. There is a commission ongoing, the Lancet Commission on Pollution, Health and Development, on which I serve, and I think our report is due out in the next couple of months or so, and look forward to channeling some of the findings of the commission into policy dialogue across the world. A couple of months ago, some colleagues and I took a stab at estimating the associated healthcare costs. Healthcare costs associated with pollution. This I did with Alex Brecker and several other colleagues. And our rough estimate came down to 3 to 9% of global health spending in 2013, with heavy emphasis on cancer, chronic respiratory, and cardiovascular illnesses. So large interval there, from anywhere from $240 billion to $630 billion. These are not small sums at all. We already mentioned demographic transitions and migrations, but I think it's important to add that this is not just about the numbers per se. They actually have tremendous implications for the extent to which countries can achieve their goals of universal health coverage, to which we all subscribe, and to which the institution where I work subscribe. It's one of the tenets. It is the central tenet of our work. Is that Siri? Excuse me. In some of his reflections a few months ago, Richard Horton actually asked whether this was achievable. I think he was being deliberately provocative there, usefully so in my view. And so the bottom line is a quest for universal health coverage a rational promise, or is it an exercise in irrational exuberance? One of the refreshing things about being back at Hopkins is that one can just let it rip. I'm having so much fun. And you also have this policymaker here who is trying to figure out the Rubik's Cube. You have to think about the coverage, and you have to think about how you're going to pay for it, and you have to think about who is covered, and the scope and the scale of services. And the poor Ministry of Health, or the poor Minister of Health, is trying to figure out how to make all of these things work. This is one of my favorite cartoons. Yet, the question remains, what exactly is the social compact underlying health? In many parts of the world, not exclusively in Latin America, the right to health is gaining traction. And I think there's something to be said for what citizens expect of their countries and what citizens expect of their governments. So this is the salute there. Now, let's turn to the role of the state and the market in financing, service delivery, and regulation of health systems. Because I think it's fair to say that a number of folks in this school, when they graduate, end up in positions of policy influence in one shape or form at the local, country, or regional or global levels. So here we go. There are major market failures in the health sector. We know that. There is asymmetry of information. There is adverse selection that plagues health insurance. And there are serious barriers to entry, which are well documented. And so markets fail. Or as Joseph Stiglitz colorfully put it, he says that the reason that the invisible hand often seemed invisible was that it did not exist. So, does it mean the government must do everything? Well, we also have government failure. So failure is not the exclusive preserve of the market. Yet there persists what I would call perhaps a misguided ideology in some quarters that the pursuit of global health goals necessarily requires the exclusive use of public means in financing and service delivery. I don't think that is necessarily the case, but I stand to be educated by colleagues this afternoon. So how does one calibrate the balance? You're out of Johns Hopkins now, and you are the principal advisor to the Ministry of Finance or the Minister of Health, or you are teaching that's graduate school in your country, or you're in some regional institution. How do you manage this vexing balance? When informing policy and practice on a large scale, emphasis on a large scale, let's keep in mind the social narratives. What are the values of that society? And always ask the compared to what question, because I think one of the failures, if you like, that I've sometimes seen in the global public health fraternity and the global public health sorority is an implicit assumption that unless something is perfect, it is not worth doing. Nothing could be further from the truth. So let's continue to ask ourselves the compared to what question. If I can raise something from 20% to 65%, maybe I should do it. And then keep striving to get better. Maybe I should not say Unless I can go from 20% to 100%, then I'm not going to do it. And as a North Star, when in doubt, I think it's fair to insist on better equity and let everything flow from there. But the bottom line, in my view, is to keep in mind that if you really want to be effective in policy influence on a large scale, then ideological absolutism and romantic attachments to perfection are not virtues in public policy. Now, it will be incomplete to have a session like this without speaking a little about the future of development assistance for health, or aid for health. I've taken this slide from a recent presentation by Lawrence Summers, the former Treasury Secretary of the US and former Chief Economist at the World Bank. So this, I really want to be sure to attribute this to him. He was president of a school, a tiny school up north there. Now, seriously, that the current allocation of donor financing for health is 20% global and 80% country-specific. And the annual total there was 22 billion. This was an address that Professor Summers delivered in Doha last year at a working group that I attended. Now, the question is the following. What is the right split? I'm not sure that anybody truly knows. But then he offered some very interesting and provocative questions, making the case for quote-unquote aid reallocation. Perhaps donor support is actually inferior. Those of you who have studied some of Angus Deaton's writings will probably find some of this familiar. Well, countries are getting richer, so maybe it's time to take a second look at the way these monies flow. And perhaps the global functions have the highest returns on investment, if you think of it in terms of public goods, generally speaking. So where do those arguments lead? I'm itching to hear responses from you. One of the luxuries of being outside of academia is that you can come into academia, pose these questions, and then make a plea for answers that you can then take back to your institution. So then we go. Now, this being a graduate school, I think the session would not be complete unless we actually did a real-life case study. So I'm going to zip through one for the next few minutes. Some years ago, there was a problem of failing antimalarials. Chloroquine was failing, SP was failing, and so a group got together to try and find a scalable business model to ensure access to effective and affordable antimalarials. That was convened by the then Institute of Medicine, that's what it was called at that time, and led by Professor Kenneth Arrow, who passed away a few weeks ago. And they achieved a breakthrough. I was not a member of that group. I learned from them that a sustained global subsidy was the way to go at the top of the supply chain, and then you let it flow through the established supply chains in country, public and private, and they will reach, presumably, every corner of the countries. Well, how did it go in practice? So building on their work, we conceived this enterprise called the Affordable Medicines Facility for Malaria. I led that exercise at the Global Fund from 2009 to 2012, and was an extraordinary privilege to do so. We sought to reduce retail prices, increase availability, crowd out the monotherapies, which were not desirable, and increase the use of ACTs. You've got to like this little girl's smile. So there was an independent evaluation. This was a multi-country pilot. I dare say probably was one of the largest pilots ever done in global health. Covered about 8 countries. I'm not going to read this out because I know everybody in this room is literate. So the findings are shown on the left and the interpretation shown on the right. This study came out in the Lancet in the fall of 2012, led by Sarah Toffer and others from the London School of Hygiene and Tropical Medicine. In short, it worked. So you set out to do an experiment, you establish a baseline, you exercise the intervention, and then you have it independently evaluated by an entity that is separate from the executor and that is separate from the beneficiary countries. So what happened? This was an article written by Kenneth Arrow and several others in the Lancet in December 2012. And they basically expressed fears that the evidence was going to be cast aside and decisions made not with the evidence, but despite the scientific evidence. So the question then is, how well does global public health handle evidence? In the end, the decision that was made by the board of the Global Fund was to discontinue that enterprise in that form and to fold it into the pre-existing business model by saying it would be integrated into that previous business model. To which Barry Bloom, up the road in Boston, responded, "This raises a lot of worries." And Ken Arrow, rest in peace, asked, "In what world does it make sense to abandon a simple program that saves lives?" For those of you working in a school that is dedicated to saving lives, millions at a time, that is a question that you might want to ponder. In what world does it make sense to abandon a simple program that saves lives? So, for reflection, we've had a quick 25-minute-ish tour of current and imminent threats to global health. We have taken a look at some of the commitments of the global community in the form of the SDGs, for example, as well as universal health coverage. And we have looked at the vexing question of the balance between the roles of the state and the role of the market, among other things. And we have done a very brief case study. So here we are. What does this mean for the second century of the Johns Hopkins Bloomberg School of Public Health? What do they mean for teaching? What are the implications for research? For policy, because a number of faculty here are engaged at the interface between academia and policy influence. And a number of the students here will go into that role. And also for programs that disproportionately benefit the poor. Thank you.
So we now have, let me turn this on actually. This is being recorded, so it's important that we use the mics, and it's important that we know how to turn it on. There we go. Okay, so if people want to have questions here, if you can come, we have 2 mics at the side. I think the other mic will need to be put on. But first of all, thank you, Soji. That was a great talk, very challenging, and I'm sure that there's lots of questions. Let me start off with one that basically turns back some of the questions you asked to us back to you. You raised the problem of how do we look at health more broadly beyond just the healthcare system. When you started, you had the big picture of the SDGs with the big picture of health in the middle and everything around it. Well, you know, if we can move away from some of these ideological abstractions about what it means to work across sectors, what are some of the practical steps you think that can be taken on the policy side, on the research side, that actually leads to some of this convergence around well-being that gets us out of the way of thinking just in healthcare systems and more into this broader vision that you've described around the SDGs? Some practical steps.
Thanks, David. I would like to take us out of this room, and let's go to the Sahel. Let's go to the Sahel belt of West Africa, which are some of the highest total fertility rates to which I alluded. And I think the illustration there is, if you want to tackle a problem like that, it's very important to understand the social construct of the society. And that while it might be possible and perhaps desirable if you're doing a small pilot in a small district or small sub-district to focus purely on traditional family planning and IEC. It's a completely different enterprise if you want to work across 6, 7 countries. So one has to understand the social narrative, the power dynamics across gender in the society, the internal calculus that each family makes in terms of the education of girls, the relevance of religious leaders to large-scale decisions in the countries. And so that brings together sectors like education, gender consideration, for example, broad social development, before you even talk about, quote unquote, the traditional health sector. So in that context, the World Bank where I work, we're working with a number of countries there on this program called the Sahel Women's Empowerment and Demographic Dividend Project. It's not an accident that family planning doesn't even appear in the title, because it's a much more complex enterprise than that. And if we go elsewhere, then I would say if we're talking about tackling infectious diseases and also tackling malnutrition, it's very important to do business with our colleagues working on water and sanitation. That way you get a more holistic perspective, and also you can reduce the incidence and the prevalence of those diseases to start with. It also has a spin-off, by the way, that if you fix your water and sanitation sector, there is less consumption, or there's less need for the consumption of antibiotics, and that has spin-off in terms of reducing the pressures on the bacteria there.
Okay. Any questions here from the audience? Yes. You can go to the mic there. It's right underneath here. No, not yet. Oops. Here we go. We need a light bulb.
Thank you very much for your speech, Dr. Adeyi. I enjoyed it very much. Anna Karenina, that quote is always very interesting to me. Every family is dysfunctional in its own way. I might be rephrasing.
But so this school as a whole is very happy. I just wondered, I want to be on the record about that.
Okay, I've recently been, I'm very interested in primary healthcare development in Nigeria, and that's very complex, the history of it and the mistakes and everything. And I've been thinking a lot about, so we know a lot of people have done a lot of research, everyone's giving recommendations if you read articles. So we know what needs to be done, but in public health, there's always the question of how can we translate evidence to policy, and I think that was central to your speech. So for a very long time, I was grappling, and I think many people who enter a field like this, you grapple with this idea of regardless of how much I do, there are always lives that are lost. And regardless of how much we give, there's always so much that ends up not being done. So recently, so I actually went for another talk yesterday, and it opened my eyes to the fact that every system is complicated, but every system can be navigated because it's a system, regardless of how disorganized it might seem. And I think you reiterated that in your speech as well. I got that sense from what you were saying. So I was wondering if you could speak more to how do we walk into a system that looks like a complete mess? There's no map, there's no way, it looks impossible. What are practical steps for navigating a system, especially when you come from the angle of social constructs and power dynamics and just the landscapes of, so we're thinking about, okay, so how do we get policymakers to listen and say, okay, this is what evidence says, this is what we need to do. I find that it's not enough to come in and say, well, this is what the evidence says. They're not going to listen anyway. So how do you work through the political system? I feel like public health can play the game as well. How do we play the game? I guess that's my...
Fascinating. Fascinating. Let me say first, I want to congratulate the faculty because it appears as if there's a thriving enterprise for piercing political analysis in the school. I think that is fantastic. Second, I want to note that probably one of the authorities on complex adaptive systems in health is Dr. Peters, who is in this room. But since he's my good friend, I'm not going to push the question onto him. No, seriously. I think it's very important to understand the evolution of the system itself, because in most countries, in my experience, the internal logic of even a seemingly dysfunctional system is impeccable. I'm not saying it's good, okay? So this is not a value judgment. I'm just saying that if you look at the internal logic of each system in most parts of the world, the internal logic is very sound. So if you look at the internal logic of the health system in the United States, if you take the trouble to understand the history of the United States and the social pressures, etc., and the narrative, then it's actually eminently reasonable. The logic is impeccable. Now, I didn't say that's good for efficiency, I didn't say it's good for effectiveness, and I didn't say it's good for equity. So what does it mean here? I think if we try to boil this down to the policy objectives of a government or the policy objectives of a country, you're trying to increase coverage with essential health services of good quality, so effective coverage. And you're trying to ensure that the patients who access those services do not suffer financial hardship at the point of consumption of those services. And then at the back of all of those are what I would call the public health institutions, the public health services, and all the services with good positive externalities. The struggle within each country, therefore, is the following. How do you organize the services so that how do you organize the healthcare delivery system within the broader health system so that it delivers for those who need it, especially the more disadvantaged? Secondly, how is it paid for? And this is where, and by whom? And what is the inherent redistribution if, in fact, you're pursuing equity? Because every society involves a struggle between those who are healthier and those who are less healthy, those who are wealthier and those who are poorer. And let's face it, you do not have to be a communist and you do not have to be a socialist to say, in that sense, a measure of redistribution is inherently desirable. Now, the problem in the system that you talked about in Nigeria, actually, a few months ago, I wrote a little short piece on this in the Journal of Health System and Reform, which is run by Michael Wright, is the following, in my understanding. I think while there has been progress over many years, and one has to note that there has been progress, the progress falls well short of what is desired. And my diagnosis of it was that at its core was the absence of a consequential compact between the population and the government. It's not just the absence of a compact, a consequential compact between the government and the people. Okay? And most things flow from there. I'm not going to repeat the entirety of that paper here, but I would just like to point out that in the absence of very robust planning, research, and metric functions, in the absence of the enforcement of the country's own law that says 1% of consolidated revenues will go to health, then you're dealing with very unstable financing. Okay? Plus all the problems of public financial management. Okay? So it's a wicked problem, if you may allow that expression. But interestingly, actually, I came to a very positive, I came to in what I would call a conclusion of measured optimism. I did not look at it in terms of doom and gloom. I actually thought that these were things that were fixable, but I'll be happy to continue discussing with you offline.
Great. Does anyone else have? Oh, I'll bring it over there then. Excuse me. Sorry.
Hi, my name is Jenna. I'm a student at the School of Nursing across the street and hope to one day grace the halls of this school. But I was also a Peace Corps volunteer in Tanzania, and then
Habari yako?
I really appreciate your presentation. And after returning from the Peace Corps, I worked in the Maternal and Child Health Division at USAID for about a year and a half, and then decided to go the clinical route rather than the management route. But while I was there, there was a noticeable shift from depending on donor aid, and I got to use Tanzania as my like case study for observing these things happening, like a shift from donor aid into this idea of domestic resource mobilization, which kind of the three questions that you had posted, I think there were Mr. Arrow's questions that you posted that you were like, donor aid is not enough, and there were a couple other questions up there. Are you gonna put it up? Okay.
Keep talking. I'll
Yeah.
find it.
So that kind of seems like the logical answer is instead of countries being dependent, there are countries that have like more than 50% of their health budget depends on donor aid. Yeah, so donor support is inferior. Countries are getting richer, which some are not, but the ones that are, they are starting to have their own resources, and there's kind of this like false dependence on donor aid, and then using their own resources to pursue kind of accessory activities instead of putting it into aid and putting it into health activities like we would like them to, like to become self-sufficient. So I'm just curious about how the World Bank pursues domestic resource mobilization. I'm sure there's a lot been developed since I left the public health world, but yeah, so I just wanted to hear your thoughts on that.
Thank you. David, should I take that?
Yeah, go ahead.
Yeah. On the question of how we pursue domestic resource mobilization, let me back up a bit. There's a piece of work that several colleagues and I are doing, and we're looking at the prospect for domestic financing to achieve what is called the grant convergence, if you remember the paper written by the Commission on Investing in Health. And of course, we observe that as economies grow, total health expenditures increase. It's actually a very beautiful line, very nicely correlated. But when you decompose it, you'll find that in a number of countries, quite a chunk of that increase is not necessarily public health expenditure, it's private health expenditure, and it's private health expenditure of the worst kind, private out-of-pocket expenditure at the point of service delivery, which is, exactly what you don't want to have. So that's one. A second consideration is that even setting that aside, quite a few countries will not be able to finance their core packages of services, of essential services, by 2030 or 2035. Quite a few of them. Which means, all other things being equal, and I want to be very explicit about this, I actually think that there is a very serious case to be made for continued development assistance for health. But that development assistance for health is best when it is grounded and serves the country's own programs, when it is grounded in and serves the country's own strategies, and when it is on budget rather than off budget. So it's not so much aid or no aid, in my understanding. It's more about the quality of aid and the purpose and the focus of aid. Now, from a political perspective, from the point of view of domestic policy and the point of view of domestic policies, I actually think that it's very healthy if the country's own tax income forms the basis for financing the publicly financed aspects of its health system. Because then the country has a greater stake, there is a greater propensity to accountability there, which might not be the case if it were heavily dependent on off-budget development assistance that is divorced from or divergent from the country's own medium-term expenditure framework or the country's own annual budget. That really is the crux of the matter. Did I begin to answer your question? Thanks.
Can I ask a follow-up question on that? Because related to the second question, there's an implication that as countries are richer, they need less aid. But And that's sort of that transition and the trade-off. But is there also an argument about differences between countries that are more inequitable in their public spending than others?
Yeah. So this, great question. You can tell that was coming from a professor. So this goes to the idea of the quantity of expenditure and the quality and fairness of expenditure. If I would dare say that as countries go richer, it's a little more complex than just whether or not they need less aid. It's also a very artful combination of how much investment comes from public sources and how much investment comes from private sources. It is arguable if you took a hypothetical country, and this is not completely hypothetical, but I'm not going to mention names now. But if you took a hypothetical country that's already covering its basic services, its vaccines, its bed nets, its basic maternal and child health services, but that has serious and seemingly intractable problems in managing its public, its secondary and tertiary hospitals, because as you know, those are very, very hard to manage. It stands to reason that those are things that might benefit from private sector engagement, because there is nothing inherently governmental in running a hospital. There is something inherently relevant to public policy in putting in place legislation, in putting in place accountability mechanisms to ensure that the financing of hospital services, for example, is fair and equitable, and to ensure that they deliver care of high quality. So I'm trying to separate the stewardship function from the delivery function. Okay? And then the second part of your question was about?
Well, if there's, it was really related to the inequities of countries' spending, and if inequity makes a difference in terms of decisions about how you look about donor assistance.
Yes. I think this comes to the question of a distinction between, I'm going to use the word donor more broadly now. And I'll say that there are three windows of engagement for quote-unquote a donor. One is the analytic window, actually co-generating the evidence. The second window is the policy dialogue window, making sense of the numbers, helping to ensure that major policies are informed on the basis of evidence. And as you can see from the last case study, that is not necessarily the case, but set that aside for a moment. And then the third window is the financing. It would seem to me that the question that David has asked is actually heavily related to the first and second windows, because presumably the country also has its own money. So how do you work with a country to make better, more equitable use of its own money to start with? And that I want to put forth is especially more challenging than just bringing additional funds into that country. Because you do have varying degrees of elite capture across countries. And for those of you who have been following the debates about health reforms in the United States over the last decade or so, and even before then, you know that inequities and elite capture are not limited to low and middle income countries.
Adnan, did you want to ask a question?
Soji, thanks very much. That was a great talk, as usual, and provocative. I wanted to go back to some of the early slides that you presented about SDGs, thinking about health systems outside the narrow confines of health, and ask you to reflect on two things. One is ownership within the health sector. So as you are looking at those SDGs, there are issues that affect health that don't necessarily emanate from the traditional conceptualizations of health or public health even. And once you go outside the boundaries of eminent schools of public health, it becomes even more difficult. So I work in the area of injury prevention, and if you look at, for example, something like road traffic injury, today, ministries of health find it very difficult to even own that. They don't see an ownership in that problem. The flip side of that is that when they begin to work outside the health sector, The other sectors don't see the Ministry of Health necessarily involved in that process in solving it either. So we have a framing and a perception issue that, of course, emanates from the conceptual framework which people are using. And I don't think we've done, and we are part of the issue here, we've done enough of our work in breaking down these barriers, which have been established for decades to come. But I think that requires a breaking down of barriers.
I couldn't agree with you more, Adnan. In addition to the framing and the perception, I'll say there's the ownership issue. Because quite often, not always, the Ministry of Health is among the weaker, if not the weakest, of ministries when you look at the cabinet. Okay, that is not a judgment on the caliber of the person. It's just a statement of fact that we've observed in many cases. Secondly, there are some of these issues that are perhaps best owned at a supra-ministerial level. So think of it in terms of a conceptual framework as an emphasis on the goals to start with, and then a very specific question, which is, where does this rest predominantly? You might actually find that it makes a lot more sense to have some things sit in the office of a prime minister, but with the explicit understanding that the execution is still going to be through different sectors. So let's stick to the road traffic accident, which means you're talking about transport, we're talking about communication, we're talking about public works, but we're also talking about the management of casualties from road traffic accidents, and it cuts across all of those. So that would be my perspective on it, that there's the ownership question, and then there's the framing and perception question. For us in the World Bank, the way we try to come at this is we're about health via health systems. We're not about the health sector per se. And so I'm very happy to do business with my colleagues in agriculture, in infrastructure, in water and sanitation. And because we have an interest in reducing tobacco consumption, then I go and buddy up with my colleagues who are working in macroeconomic and fiscal management, because if I want a country to hike tobacco taxes, then it's not the doctors who are going to help me figure out the mechanics of that. It's people who know how to navigate taxes, fiscal policies in the Ministry of Finance. So red alert to all the students here. Try and buddy up with people in the Department of Economics if you can. Spend a lot of time drinking coffee with Adnan and with folks with whom you normally would not want to buddy up, because when you get out of here, your reality is going to depend on them. Was that a good plug?
Yeah. So, and you can tell who's in the Ministry of Finance because they have better suits. Okay. Okay. Any other questions at this time? Well, then let me ask you to give a round of applause to Dr. Adeyi.
Thank you.
And
thank you.
Thank you. Thanks very much. But I also want to recognize your contributions, and thanks for this lecture. We have here one of the famous contributions to global health from the Department of International Health. So we're happy to
Thank you.
pass this on to you.
Thank you very much. Thank you. Appreciate it. Thank you.
Thanks. So,
thank you. Appreciate it. Thank you.
So we have
I should come back every day.
You should, yes. Well, you don't have to go yet, because we have a reception outside in the gallery where we can mingle and talk one-on-one, and you can grill Dr. Adeyi about what he would rather be studying now if he could do it all over again, or anything else, or insiders. How do you get to the World Bank from here, or and etc. So please join us outside in the gallery for a reception. Thanks very much.
Thanks everyone. Thank you very much.